Good evening, LBK.
Good evening, sir.
You're muted.
Yes.
I hear you.
First, I welcome to this program of Tnisg e-meeting, and this has been this time allotted to us in Coimbatore. I'm really thankful for the Tnisg for giving us this opportunity. So, the program includes 2 case discussions, one from PSG Institute of Medical Sciences and Coimbatore Medical College, followed by the regional vignette from by Dr. about Coimbatore by Dr. Madhura Prasad, followed by a talk by Dr. Naresh Bhatt from Bangalore on how enduring the pain. So I hand over to Epen, Dr. Epen, for starting the proceedings. Thank you.
Okay. Thank you, Venkat. Welcome everyone to the second edition of the e-meet. This is a nice initiative by Tnisg, hoping to have inclusiveness and to get different extra mural or outside of Chennai centers and members to participate, as well as students to get an opportunity to present. The trick is to start on time and finish on time. So I wish the meeting all success. Thank you.
We have 1 more minute to go. 59.
Okay.
Yes.
Yes, sir. We'll just wait for a minute, sir. Probably 7.
You can start. We are ready.
All right.
You feel that.
Sure. It's almost we got 1 more minute and we'll be good.
Sure.
That's fine. Accordingly. That's right. Good evening to all members and students. I welcome you all to the second edition of this ECME. And as been discussed, this will be with an aim to include postgraduates who are being trained outside of Chennai, to have a forum for them to present and also get the interaction from senior members and faculty across Tamil Nadu. So, Machado, I think we have a couple of case presentations followed by a small regional vignette. And that is interesting because I find that most of the postgraduates are from outside of Tamil Nadu. So I think they will have some idea as to what is special about that center from where it is being presented. The first edition was from Vellore. The second edition is now from Coimbatore. So I think we'll have a 5-minute session about what's special about Coimbatore, followed by a guest CMA lecture by Dr. Naresh Bhatt. So I would request all the presenters to keep to their time. To start off with the case presentation, I request the moderators for the first case presentation, Professor Jayanti and Dr. Rajesh, to take over and conduct the proceedings, please.
Who's presenting the first case?
Dr. Karthik, sir, madam, from PSG.
Good evening, madam.
Please start.
Shall I start, madam?
Please do, yeah.
Good evening, everyone. Today I am going to present a case of cholestatic jaundice. A 37-year-old male with no known comorbidities presented with complaints of yellowish discoloration of eyes and urine, which is insidious in onset and gradually progressive, associated with itching and pale-colored stool since 2 months. There is no history of prodromal symptoms, alcohol or alternate medicine intake prior to the onset of jaundice. No history of abdominal pain, fever and chills. No history of abdominal distension, pedal edema, GI bleed or altered sensorium. Patient also has history of weight loss of about 7 to 8 kg in about 1 month with normal appetite. He also complains of loose stools 10 to 12 episodes, watery, small amount, non-blood stain, non-mucoid. Past history, there is no history of abdominal surgeries in the past. Personal history is not a known alcoholic smoker, no history of any high-risk behavior. General examination, patient is conscious oriented, BMI is 20 kg per meter square, pulse rate is 1 or 2 beats per minute regular, blood pressure is 110 by 80 mmHg, febrile, JVP is normal, icterus is present, but there is no pallor, cyanosis, clubbing, lymphadenopathy or pedal edema. Exophthalmos was present, but there is no neck swelling. Scratch marks are present. There are no signs of chronic liver disease or no cutaneous markers of malignancy. Systemic examination, perabdomen is soft, liver not palpable, spleen not palpable, gallbladder is not palpable. There is no ascites. CVS S1, S2 heard no murmurs, CNS no tremors. Labs, CBC hemoglobin is 11.6, TC is normal, platelets are normal, INR is mildly elevated, 1.62. LFT wise, there is direct hyperbilirubinemia with transaminitis with SGOT more than PT and ALP and GGT elevation with ALP elevation more than enzyme elevation. Cholestatic pattern of jaundice with R factor of 0.6 and hypoproteinemia with low albumin and globulin levels. And urea and creat are normal, but urine routine is normal. There is no evidence of protein loss in urine. Urine PCR is 0.1. The etiological workup for cholestatic jaundice. Viral serology, HBsAg, HCV is negative, HIV, HCV is negative. Autoimmune workup, ANIF, ANA profile and liver IgG profile is negative. Serum ceruloplasmin is normal. Serum IgG is 17. In thyroid function tests showed low TSH with elevated free T3 and T4 levels. Anti-thyroid peroxidase antibodies were positive. This is the etiological workup for cholestatic jaundice. Negative viral serology, autoimmune workup is negative. Ceruloplasmin, ferritin is level. ECG and 2D echo is also normal. USG abdomen was done to look for any IHBR or extrahepatic obstruction. USG abdomen showed liver is normal in size and echo texture. No IHBR dilatation. Gallbladder is normal. CBD is not dilated. Pancreas was visualized head and body appears normal. CECT abdomen was done. It showed a normal liver size, IHBR not dilated, no evidence of portal obstruction, portal vein is normal, gallbladder is normal. There is no features of extrahepatic obstruction or IHBR dilatation in CT. In view of hyperthyroidism, radioactive iodine uptake scan was done, which demonstrated 90% diffuse uptake of radiotracer, which is consistent with Graves' disease. To evaluate for alternate etiology, a transcutaneous liver biopsy was performed. This liver biopsy showed Mallory bodies and feathery degeneration, lobular disarray, and giant cell hepatocytes, and cholestasis with rosettes and portal inflammation. So the constellation of deranged thyroid function tests, cholestatic jaundice associated with diarrhea, significant weight loss, cholestatic inflammation on biopsy, positive anti-TPO antibodies, and absence of other causes of cholestatic jaundice made us assume that the likely cause was untreated Graves' disease. The diagnosis of Graves' disease was made, and given the fact that anti-thyroid drugs were considered contraindicated in liver disease, patient was started on propanolol 20 mg OD, prednisolone 20 mg per day, and cholestyramine 2 grams 4 times a day. The patient showed a favorable response with notable decrease in hyperthyroid symptoms and normalization of T3, T4 and T3 after 1 week of treatment. Later, he was treated with radioactive iodine therapy. Periodic follow-up showed progressive decrease in bilirubin levels. Hepatic involvement in hyperthyroidism ranges from mild liver test abnormalities to severe cholestasis. What are the causes of hyperthyroidism and jaundice can be due to 4 causes. One is hyperthyroidism per se. Why it occurs is this hypermetabolic state in hyperthyroidism increases the hepatic oxygen consumption without increasing the hepatic blood flow, thus lowering the oxygen tension in centrilobular zones and interfering with bile transport, resulting in cholestasis and increased rate of bile flow to point of saturation. So cause is cholestasis. And second is jaundice may be due to antithyroid drugs. Here in this case, there is no use of antithyroid drugs. Third is jaundice due to thyrocardiacs, maybe because of atrial fibrillation or right heart failure. In this case, ECG is normal and 2D echo showed no evidence of right heart failure. then jaundice can be in association with autoimmune diseases such as primary biliary cirrhosis or autoimmune cholangitis. Both are negative. Both methimazole, carbimazole, and propyl thiouracil have risks of cholestatic liver injury, but overall lower liver failure risk. In the setting of liver dysfunction, these risks may be increased and should be carefully weighed against these therapy benefits. Radioactive iodine ablation therapy may present the preferred modality for treating Graves' disease patients with liver dysfunction, but further evidence is required. Thank you.
Yeah, Karthi, it was a nice presentation.
Thank you, sir.
This is autoimmune hepatitis or biopsy suggestive autoimmune hepatitis, or
Sir,
it is not?
Biopsy is negative for autoimmune etiology, no interface hepatitis, sir.
Yeah,
No
that's
skin fibrosis or no evidence of granulomas. Only cholestatic hepatitis, sir, biopsy was.
Yeah, usually, in autoimmune hepatitis, they have other alternative autoimmune etiologies like hyperthyroidism may be there. But here it is hyperthyroidism we have. Patient has a cholestatic hepatitis. So whether you want to say it is a autoimmune hepatitis, probably in future may go.
This is the hyperthyroidism per se, sir. Autoimmune hepatitis ruled out, atrial fibrillation ruled out, right heart failure ruled out, anti-thyroid drugs ruled out. Only hyperthyroidism per se. Because all autoimmune workup is negative in this case.
Okay.
ANA profile, liver IgG profile, serum
1 minute.
IgG.
Doctor, 1 second. What is the prevalence of this type of a problem in hyperthyroid states? Graves' disease?
It is very rare, madam.
No, you should have told us the prevalence, no? I mean, Graves' disease is not an uncommon problem seen by the endocrinologist. And this is one of the few occasions that we have come across with jaundice of this type of a presentation. So can you tell us the prevalence?
Data, actual prevalence data, I didn't get any of the literature, madam. Actual prevalence of the data. I searched almost 20-30 articles. I never got any prevalence. Only 20 to 30 case reports are there.
No, but what have you said? The 20 to 30 case reports, what do they say? What is the mechanism? And why is it so
uncommon? In few cases, mechanism is hyperthyroidism per se. In few mechanisms, because of untreated Graves' disease. In few mechanisms, because of associated autoimmune diseases or primary biliary cirrhosis.
Anyway, I think
Hyperthyroidism per se is very less, madam. Associated with autoimmune diseases or right heart failure, few case reports are there.
okay, anyway, this is a rare presentation. I think in a given case, I think we should consider all of the possibilities other than considering hyperthyroid state per se causing a cholestatic jaundice. I think that's the message.
Yes,
Yeah.
ma'am. Because everything is ruled out.
Agreed. No, we may still have missed few things. Okay.
One more.
Epan would have told you. Your comments, Epan? Should we include a celiac disease?
No, I agree. It's a very interesting case. And like Dr. Jayanti highlighted, it's nice to know which of these would you rate as the commoner, what is the commonest thing? I think commonest, I would say, is what?
Autoimmune diseases. Associated.
Is autoimmune. That's
Yes.
right. This is what Rajesh mentioned. So it's good to have a sense of that as well, to say. It just crossed my mind that one of the drugs for fatty liver disease is also targeting a thyroid receptor in the liver.
Saraglitazone.
No, resmetirom. So that's an interesting side thing to think about. Yeah. No, I had no other comments. Thank you.
Thank you, Dr. Karthik. Can we go on to the next case?
Thank
Thank
you.
you. Very interesting.
Other thing we
Thank
just
you.
want to highlight is, even though there was some cholestatic rosettes, there were no classical hepatocyte apoptosis or interface hepatitis or very severe plasma cells. We did biopsy thinking that it could be an autoimmune hepatitis, but the pathologists were very certain there's no features of autoimmune. And at the same time, they said there are no specific liver findings in a dysfunction due to hyperthyroidism. There are no specific liver biopsy findings for these patients. There's no liver-specific hyperthyroidism causing liver dysfunction. And the steroid was used to bring down the
T4 to T3, thyroid storm steroids to decrease the conversion of T4 to T3. And propranolol also T4 to T3 conversion.
was done.
And cholesterol was used to decrease the absorption of bilirubin and
Biopsy was done after how many days of steroid?
But
No,
after
after biopsy only steroids.
after the diagnosis only we started steroids, madam, to decrease the thyroid storm.
The one is that or to reduce the cholestasis, either way, no?
Which one, madam?
Steroids will also have a washout phenomenon. So I think alphas, gamma GT are all normal.
Yes, madam.
So it's just a bland bilirubinostasis. That's the
Bland
way-
steroids.
Yeah. Thank you. Can we move on to the next case?
Thank you.
Thanks. Nice presentation.
Thank you.
Who's presenting the second case?
This
Yeah.
is from Coimbatore Medical College.
Okay. Malti, you have any comments to make on the first case? Hyperthyroid with cholestatic jaundice. Malti? Make any comments? You're muted. Can you unmute, Malti? Yeah. Your comments, Malti?
I think it is a very interesting case of hyperthyroidism. No? So I think first what will strike us is the autoimmune. Though we can have a seronegative autoimmune injury. So I think we just have to think, but I think LVK is now very good in his hepatology. His pathology report also is very, very clear. He is able to say that there are no certain things which are there. Just have to follow it up. Now, once we give steroids, the whole thing changes. I think all of you will agree with that. Now, next time when we follow, we won't know what is happening. That is one thing about thing. What is your plan, Dr. LVK, for this patient?
Steroids were stopped, madam, and then he underwent radioiodine ablation and is doing perfectly, much better now. Steroids was just given for a few days to just because they were worried about the thyroid storm. They want to bring down T4 to T3. That's exactly what they did for. So we didn't give any steroids and we went ahead, but the endocrinologist preferred a radioiodine ablation, which was done here. And then patient has now, the bilirubin has now started coming down very well. He's only on treatment for hyperthyroidism.
What was your final diagnosis? Cholestatic hepatitis?
Secondary to this is liver dysfunction secondary to hyperthyroidism. We have excluded autoimmune hepatitis by serology, IgG, and the pathologists were very, very certain that this is not autoimmune hepatitis by biopsy. They said this could happen. At the same time, they said they have not come across any particular findings of liver dysfunction. And
so IgG also was not elevated.
IgG was also normal, ma'am. It was only
globulin and IgG was normal.
70. She had only, even the enzymes, you look at it, the enzymes were not much elevated. It's only the alkaline phosphatase and gamma GT was grossly elevated. He had a lot of exophthalmos when he came. That's the time. He was referred to as jaundice with us.
I still feel it may be some syndromic, Anyway, can we move on to the next case? Yeah.
Sure.
Dr. Omkar Singh.
Yes, ma'am. Good evening to all esteemed faculty members and my dear fellow PG students. So
Video, let's see you. You're from North India, South India, Eastern parts of the country. That's good, Singh. Chalo, batao.
I'm presenting a case of rare case presentation. I have kept an acronym for this case as CT, which I'll reveal at the end of the discussion to make the things interested. So I'll start with the case. So, case history, this is a 29-year-old young male resident of district Coimbatore, educated up to 10th standard, who presented to us with chief complaint of yellowish discoloration of skin and sclera since 6 weeks and generalized itching since 4 weeks. History dated back to 6 weeks when patient developed yellowish discoloration, which was initially noticed by his mother, which was insidious onset, progressive in nature, associated with generalized itching of severity grade 1 since 4 weeks and associated with clay color stools. However, it was associated with the loss of appetite. However, there was no history of any nausea, vomiting, any history of any prodrome prior to the onset of jaundice, no history of any similar episode in any family member, no history of any alternate medication history prior to the onset of jaundice, not associated with loss of weight, no history of any abdomen distension or awareness of lump abdomen, no history of any hematemesis melena, No history of fever, night sweats, no history of any passage of oily stool or difficulties to flush stools, no history of joint pains, skin rash, no history of any tattooing, blood transfusion, or no history of any night blindness, bone pains, or easy bruisability. Moving on to past history, there is no history of jaundice in past, no history of no surgical history, no history of any endoscopy or ERCP in the past, no history suggestive of tuberculosis, diabetes, or hepatitis in the past. Personal history, patient is unmarried, non-alcoholic, non-smoker, on mixed diet, with no history of any transfusion, blood transfusion or tattooing in past, and no history of any high-risk behavior. Family history, no history of similar complaints in the family, no history of any gallstones, no history of any other malignancy. So summarizing the case, this is a 29-year-old male without any addiction, presented with insidious onset, painless progressive jaundice, with generalized pruritus, pale color stool since 6 weeks, in absence of prodromal symptoms, with ECOG's performance status of 0. Since on the basis of history, we cannot rule out whether it is intrahepatic or extrahepatic, there were some soft pointers that since there is no history of any surgical history, we kept a possibility of, we kept our approach open and included both intrahepatic and extrahepatic as our differential diagnosis. Moving on, to confirm our diagnosis, we went ahead with examination. Patient was moderately built, moderately nourished, with a BMI of 25.8, widely stable, afebrile. Only positive signs were in form of icterus and scratch marks. However, there was no pallor, no papillary edema, no cyanosis, no clubbing, or no lymphadenopathy. No evidence of any xanthelasma, xanthomas, no pelvic signs of chronic liver disease, and JVP was also normal. On systemic examination, everything was abdominal examination, everything was normal. A special mention about GB being non-palpable. Other examination was within normal limits. I'll just skip. Other systemic examination was also within normal limits, including CVS, respiratory system, and CNS. Moving on to investigations, his CVC was with TLC of 10.7 with 70% polyas, with a HP of 11.9 with platelet count of 3.7. LFC showed obstructive jaundice pattern with the total bilirubin of 14.1 with a direct component of 8.6 with the ALP of 252. However, urea creatinine and other things, RBS was normal. His viral markers were negative. PCTC was non-reactive. Serum amylase lipase was within normal limits. INR was 1.18. On ultrasound, patient liver was 11 centimeter with normal echos. However, it showed bilateral mild intrahepatic biliary radical dilatation with a CBD of 8 mm, spleen size of 9 centimeter with a normal pancreas with a distended GB. OGD was done, which showed normal study with the side view scopy showing a normal ampulla. So, in view of obstructive jaundice with the ultrasound showing bilateral mild intrahepatic biliary radical dilatation with the CBD of 8 mm, we went ahead to proceed with CCT abdomen. CCT abdomen for this patient revealed a soft tissue mass of size of 4 cross 4 in segment 5 and 8. This is axial section of CT abdomen with the IV contrast. This is arterial phase showing a peripheral rim enhancement with the capsular retraction. As we proceed down, we can see there is no vascular involvement, as well as GB is also distended, but it is showing not well demarcated with the bilateral intrahepatic biliary radical dilatation. As we proceed, we saw on portal venous phase, this lesion showed centripetal filling. This finding was consistent with intrahepatic cholangiocarcinoma, but intrahepatic cholangiocarcinoma per se cannot cause a jaundice of more than 4 or 5. So probing into, we found that lesion was extending into the right hepatic duct. To know the exact longitudinal extent of the lesion, we went ahead with MRCP. MRCP images showed a T1 hypo-intense lesion in segment 5 and 8 and corresponding T2 hyper-intense lesion of size 4 cross 4 with the capsule retraction with intrahepatic biliary radical dilatation. Seeing further, the lesion can be seen involving into the right hepatic duct and hepatic confluence. Diffusion weighted images showed diffusion restriction in the corresponding lobe in segment 5 and 8. with no vascular or no nodal involvement. This is the coronal section showing that lesion in segment 5 and 8 of the liver. We went ahead to confirm the diagnosis. We went ahead to see an antenna which came out to be normal. In view of young age of presentation, we went ahead with IgG4 levels, which were also within normal limits. In view of cholangiocarcinoma, intrahepatic cholangiocarcinoma, we went ahead with colonoscopy to rule out IBD status, which revealed normal stadium. So on the basis of imaging finding, we came to a final diagnosis of intrahepatic cholangiocarcinoma with AJCC stage T2, TNM stage of T2, TNM stage of 2 stage 2 with ECOG performance status of 0 with no evidence of cholangitis. Moving on to discussion, this intrahepatic cholangiocarcinoma is second most common malignancy arising from the liver. Intrahepatic cholangiocarcinoma makes up to 10% of all the cholangiocarcinoma. The incidence of intrahepatic cholangiocarcinoma in Western population is around 1 to 2 per 1 lakh population. In India, we don't have any prospective data for that. And out of this intrahepatic cholangiocarcinoma, only minority of the cholangiocarcinoma will present with the resectable disease at the time of diagnosis. And complete surgical resection remain the only option for cure. On review of literature, this is one article published by Dr. Vivek Saraswat from northern part of this country, where they studied the profile of extrahepatic biliary obstruction, and they found out GB carcinoma to be the most common cause of malignant extrahepatic biliary obstruction, and cholangiocarcinoma stand at 10% of entire cohort. A similar article was published by team at Amrita Kochi, and they very aptly titled this article as unprecedented, unanticipated, and underreported etiology identity. The salient features from this study, I will just read the underlying things. The exact incidence of cholangiocarcinoma is unknown in India, owing to a reporting system that groups all hepatobiliary malignancies together. However, there is very little data regarding the risk factor for the development of cholangiocarcinoma in India. Certain other points, according to the existing data, cholangiocarcinoma rarely present before the age of 40, with a peak prevalence in the 7th decade. And the peak incidence in our region, that is India region, was noted around early 6 decades. Our case was peculiar in this form that this patient, young patient without any comorbidity, without any risk factors, presented at the age of 29, and that too with at a stage where the lesion can be resectable. However, there is paucity of the data from India regarding the epidemiology, risk factors, or incidence of cholangiocarcinoma, owing to the lack of uniform reporting system for cholangiocarcinoma in the country, which includes gallbladder cancer and hepatocellular carcinoma with cholangiocarcinoma. The incidence trend for cholangiocarcinoma over specified time period is unknown. And moreover, most of the cholangiocarcinoma arise de novo and no definite risk factors are identified. There is one, on review of literature, there is one similar case report of intrahepatic cholangiocarcinoma in a young patient, which was seen at as early as 30 years of age. And this article was published in 2017. This patient was from Italy. And in this patient, there was some hepatotropic opioid consumption, which heroin and methadone, which they proposed as a etiological risk factor for development of cholangiocarcinoma. For surgery is the only definitive cure with good prognosis, 5-year probabilities, and good survival benefit for this patient. So our plan of management for this patient was a multidisciplinary team approach was taken. Since the lesion was within the operable criteria, plan is to build and prepare the patient for surgery. Patient will be requiring a major resection in form of right segmentectomy, workup for portal vein embolization for building a future liver remnant to more than 30%. The patient is planned for pre-operative biliary drainage. The indication is for building patient for future liver remnant and bilirubin more than 15, which is a relative indication. Prior to the operative procedure, patient will undergo a diagnostic lab to look for any omental deposit, and further chemo requirement will be dependent on the status of R0 resection and tumor-free margin. So this acronym for my case is CT, which stands for cholangiocarcinoma in the young, which is a rare presentation in a rarest scenario.
Thank you, Dr. Singh. Wonderful case and a very good presentation. Very well presented. So, how do you explain the biliary radical dilatation on both sides, and then on what basis? What are the points to say he's got cholangiocarcinoma? What are the points? One is how do you explain the IHBR dilatation on both sides, and what are the points to say he's got a cholangiocarcinoma?
When this on arterial phase, the lesion was showing peripheral rim enhancement with progressive centripetal filling in the venous phase, which is typical, which is consistent with the finding of intrahepatic cholangiocarcinoma and bilateral.
How do you explain the biliary dilatation on both sides? No?
Dilatation was, ma'am, it was subjected to that lesion was infiltrating into the right hepatic and hepatic confluence, common hepatic confluence.
It doesn't look at in the confluence, no? As per the C, doesn't seem it is playing. It doesn't look like a hilar. It's more like intrahepatic cholangio. But how do you explain the biliary radical dilatation? So, I mean, you can see in this, the second one on the right, no, there's huge dilatation of the biliary system on either side.
This lesion was extending into the right hepatic duct and confluence, up to the confluence.
Then it's hilar cholangio.
Ma'am, the primary lesion, the big lesion is in the segment 5 and 8, which is of the diameter of the 4x4 lesion. So primary lesion was this. This was extending intrahepatic spread towards the hilar region.
A spyglass would help us in a tissue diagnosis and visualizing the tumor.
Since this lesion is found to be more of highly desmoplastic, so the yield from this spyglass might not be that accurate. Yes, we can try that. In fact, in pre-operative biliary drainage, we can also use that sample and send for cytology, breast cytology of fish, subject to fish. But
Rajesh,
Comments from
Rajesh?
Professor Prem Kumar, Dr. Sridhar.
The big tumor is missed in the ultrasound.
sorry, sir.
The ultrasound showed only a dilated CBD till the lower end.
The patient was quite obese with the morbid obesity, centripetal obesity.
Even then, the biliary radical should have been picked up. Comments from others, LVK?
Dr. Prem Kumar and Dr. Sridhar are also moderators for this meeting, please. Dr. Sridhar.
Hi, nice presentation. This is Dr. Sridhar here. The one thing which is not thing, can you show back the MRI images, the T2 images? Yeah. Zoom the second image, please. Yeah. See, you see the lesion very clearly where you see you cannot see the hilum being involved. There is a capsular traction on the other side, the lateral side. The medial side, I don't think the mass is actually involving up to the hilum per se, like ma'am said. So that doesn't explain. And the peripheral IHBR in the right side is slightly dilated. It's not bilaterally dilated. Nice. And did you find the LFT being surprisingly normal in the enzyme pattern, even though the bilirubin is 14? Your SGOT PTs were in double digits. 25 and 38, if I'm not wrong.
Yes, sir. Sir, initial presentation was like this. Over the stay, bilirubin has increased to 19, with OTPT have mildly increased to 50 something, not more than that.
Yeah, so the enzymes being absolutely normal, despite having, you're saying there is a hilar involvement with such a cholestasis, it should have a mild PT elevation with an alpha elevation. Doesn't happen. That was one thing. The next thing is, when you said you planning for what in the future to preserve the PTBD is for a relative indication of bilirubin being high. Why is the portal vein canalization is being planned?
So, since this lesion is involving the hilum also, so we are planning for a right.
No, was it discussed? Was this discussed? This, so this is because this is MR. The CT, how is it showing the vascular anatomy of the liver?
The vascular, there was no involvement.
No involvement. Okay. Okay. Great. Thank you.
For extended right hepatic infecting, you may have to include segment 5 and
5 and 8 are involved, sir.
5 and 8, so that then might have to do a portal vein embolization. But sometimes I think
Yes.
the other thing I want to tell is the age of 30 years or so. We had one patient like this, and when we operated, removed it, came out as a neuroendocrine neoplasm. He was also very young, 32 years. Went in as a cholangio. Everything was like cholangio. There's a capsular retraction, but the biopsy turned out to be a neuroendocrine lesion. It did not show up any the typical enhancement in a CT petri discharge. So we all thought it could be, it had a retraction, but he was, and you said his performance state is also good. So it's one of the reasons why I think when we operated, recently we operated, and that turned out to be a neuroendocrine.
And you said, and the presenter said the patient is obese.
NASH can also be sometimes associated with
Okay, so I think we are just about finishing. I think so. If no further questions, we move on to the next part. Thank moderators and the presenters. It was a wonderful presentation. The next step will be about the regional vignettes. To take it forward, I request the moderator, Dr. Mukund, to come on, and request Dr. Madhura to proceed with the. Tell us what is interesting about Coimbatore.
Yes, sir. So that I found a very interesting topic you've given to me. And thank you very much for this opportunity. So here I am to talk about I Love Kovai. And I'm sure many of our postgraduates here also don't know much about Coimbatore. So for those who don't know, Coimbatore is called the Manchester of South India, and like Ahmedabad is for North India. Here, it's a textile hub, and that is how, right from the cotton spinning mills, it has grown. All the businesses have evolved around that. And this is a bird's eye view of Coimbatore. So those are the lakes which have been developed as part of the smart city. So we are Order City, the city where anything is possible. This is what is being put forward. And what is very beautiful about Tamil is the Kongu Tamil, which I'm sure after being in Chennai, you would find a pleasant surprise. It's a very pleasing and respectful Tamil, which is spoken in this part of Tamil Nadu, around Erode, Salem, Namakkal, Tirupur, and Karur, and mainly in Coimbatore. And of course, there are people who speak Telugu because there are 10% of migrants from during the Vijayanagara Empire, they settled here. And there's Malayalam because we are close to Kerala, and there is a population of Gujaratis and Marathis also here. So Coimbatore has many firsts, and it gave the first bulletproof helmet in the world, the first wet grinder, which is like a very important part of South Indian food, and first electric motor paper making plant. It's like the list goes on, right, from till the drip irrigation system. And even I found this very interesting. First synthetic gems, first natural colored cottons. And then again, there are so many top industries of Coimbatore which are making waves in all fields. And here we are looking at the beautiful artistic part of Coimbatore. Coimbatore has come up with decors all over, people painting murals on walls, and it's very beautiful to see in some parts of the city. And let's go to a very ancient marvel, Perur Pattishwara temple, which dates back to 1,500 years old, built by Karigala Chola, and it's still an architectural marvel. Every part of the temple is so beautiful, and this is especially called a monolithic stone, where all the chain, this whole chain is made from just one stone. So that makes it so, many temples in Tamil Nadu have that, but this is especially noted for that. And there are many more temples, which is like Marudamalai, Koniamman temple. Koniamman temple gives Coimbatore its name, and Anuvavi temple, which is on a hill, which is a beautiful picturesque view for a trek. And here is the Mudumalai Sanctuary and Anakatti and Timbam, Silent Valley Forest Reserves. There are so many forest reserves all around Coimbatore, which probably gives it a very beautiful and pleasant climate. And for the daredevils, there are treks. And these treks are there in Velingiri Hills, Melmudi Trek, Anamalai, Kotagiri. And Coimbatore is also an IT hub. There is an IT hub here. And Coimbatore surprisingly has become like an Ayurveda retreat, and there are so many centers coming up for rejuvenation and and old retirement for old people, retirement homes, beautiful retirement homes, and attracting people from all over India. And of course, medical tourism. How can I leave that out? Especially for orthopedics, for gastro, and I'm saying gastro because we are gastroenterologists, but definitely all fields and like all there are multi-specialty hospitals, and attracting people from Saudi, from Malaysia and whatnot, Singapore. And these are attraction for children. So if people are visiting Coimbatore, you should visit the GD Card Museum, GD Science Center, and of course the Asia, and all the waterfalls in and around. There is Sirvani, Monkey Falls, Kodiveri, Kovai Kutralam. And there are 7 beautiful lakes which the city is taken up to clean and develop and have walking tracks all around. And of course, I should not forget the personalities of Coimbatore. There's R.K. Shanmugam, who was the first Indian finance minister, C.K. Prahalad, who was a famous economist, and Naren Karthikeyan, the first F1 driver. Incidentally, F1 cars, F1 racing, I think they were pioneers. Coimbatore, one of them. And if you have seen any Tamil movies, you will not forget these people. And Satyaraj, who is our Kattappa, and Surya, Karthi, and of course, our heroine. And now Coimbatore is having Happy Streets and Art Street. And this is Art Street in Coimbatore. This is Happy Street, where the street is opened up on Sunday for people to play, enjoy, make kolam and some interesting rangolis and all that. And of course, our Kovai Vira is coming up soon. So yes, so whether you're going to visit or stay on in Coimbatore, definitely you will love Coimbatore. And thank you very much. That brings me to the end of my talk.
Thank you, Dr. Madhura. I've learned a lot more about Coimbatore, even though I'm from that area. Thank you.
Thank you, sir. Dr. Mukund, you have any more comments? Anything more that you want to add? Or
probably one thing, the weather of Coimbatore. Is something which attracts people all over. It's also called as poor man's Ooty.
Thank you. Thank you, Dr. Madhura and Dr. Mukund. That was a very nice introduction to what Coimbatore is and what it was about. Thank you so much. We'll move on to the next session. I'll request Professor Palaniswamy and Dr. V.G. Mohan Prasad to moderate the session, please.
Thank you, Dr. Paramanagam, for the opportunity to chair this session. And Dr. Manesh Bhatt is familiar to all of us, and he's the head of gastroenterology after Medicity in Bangalore. And he was the past president of the Indian Society of Gastroenterology. He's a great teacher and academician, and he has a special interest in the endoscopic imaging and bowel ultrasound. Without wasting much time, can I request Dr. Naresh Bhatt to talk to us on enduring pain? Dr. Bhatt?
Thank you. I'll share my presentation. I think we should be really wasting too much time. I think we should be rushing to Coimbatore after seeing all those beautiful pictures that Madhura has shown us. Anyway, thanks, Pirma, LVK, and all of you in the Tamil Nadu Society for having me here this evening. I will share a couple of cases. This is a 60-year-old diabetic who has a history of burning pain, burning sensation on the right side of the upper abdomen for a year. And he comes to us with 6 weeks of discomfort in the upper abdomen with bloating. He had an endoscopy done, an ultrasound done locally. It showed a dilated CBD, but his liver functions were quite normal. They did a CT abdomen, and it showed only, again, just a dilated CBD. The pancreas itself was normal. So he underwent an ERCP, and a sphincterotomy and a biliary stenting was done locally. And then he came here for a second opinion. The second patient is a 51-year-old male with chronic pancreatitis. He has small duct disease due to alcohol. He's been on analgesics for some time now. He complains of persistent pain and weight loss after an initial benefit for 3 to 4 weeks. He was hospitalized again, but then he continued to have poor intake, vomiting, and distension. And obviously, the question that we was asked was, what's your plan for management? And finally, we have this patient who's a 36-year-old male, retrosternal discomfort with mild dysphagia for about 2 months. He has evaluated elsewhere, and you can see this HRM high-resolution manometry showing you that the esophageal peristalsis is reasonably okay, but you have the LES is not quite all right. Is diagnosed to have an EGJ obstruction and was advised a LES myotomy, and again came to us for a second opinion. So the big question is, what is common to all these three patients? Any guesses? Maybe I'll ask the chairpersons, allow them the guess. Palli and Vijaya.
Probably your topic is enduring pain. So I thought probably you're stressing on more discomfort and pain.
Okay, we'll move on. So this is the common thing is opium and opiates, right? All these three patients have an opiate-related problem. Just sort of discussing this a little further, we have opiates which are normal opiates, or the opioids which are the more pharmacologically available things that are made, the chemicals. So now, either of them, they just bind either in the CNS where they give us analgesia, or they can also affect by involving the mu receptors in the abdomen, and there are several sites where it can bind and inhibit bowel function. The peripheral opioid antagonists do not cross the blood-brain barrier. Therefore, they can be utilized to sort of reduce the adverse effects of these opioids. Looking at the GI tract per se, you realize that you can have involvement right in the esophagus. When they increase the pressure of the lower esophageal sphincter, they can affect the biliary tract, if gallbladder function or the sphincter vodi can be affected. It can increase the pyloric tone, it can decrease gastric emptying, and it can affect intestinal peristaltic contractions. It can affect the anal sphincter tone, and so on. So there are several areas where these opioids can act, because we have these mu receptors there which enable these opioids to exert a kind of pharmacological action and change the gut physiology. One of our patients had opiate-induced esophageal dysfunction, and they present with various kinds of symptoms, including dysphagia, and they often resemble EGJ obstruction with an increased IRP and distal latency. We all realize that there are many causes for this. For an EGJ obstruction, there can be a mechanical obstruction, there can be a growth there. Some of them may resemble a type 3 kind of achalasia. But I'm sure Jayanti and others, Srini, who are into manometry, will tell you that this is a very dicey area. And what looks like EGJ obstruction can, over the next few months, turn out to be normal. But it's also important to realize that opiates can cause the same problem. This is a paper from my friend Marcelo Vela, who's in the Mayo Clinic, and he showed us that not only can you get EGJ ocular obstruction, but you can get features such as distal esophageal spasm, a type 3 achalasia, or even a jackhammer esophagus, all due to opiates. So it can be a great mimic in the esophagus, and therefore one has to be careful before making a firm diagnosis, because some of them may be reversible once you get these patients off the opiates. In fact, in this study that came out just very, very recently, is that out of 89 patients with type 3 achalasia or EGJ obstruction, opioid use was present in 20%. That makes it a fairly important cause of esophageal symptoms, including dysphagia. Opioid-induced constipation, I think all of us know. I won't dwell on it further, but it's extremely common. We see a lot of patients who take opioids in short term, they get into constipation. So I'll skip this part of it. But if you look at what can we offer them, treatment, we realize that the classical laxatives that we use in day-to-day practice, the first line, have a very modest response. And interestingly, the newer laxatives that are available, like lubiprostol and prochloropride and so on, actually have very little benefit and are not recommended. These specific medications, which are called the peripherally acting mu receptor antagonists, or PAMORAs, you have these names, some of them not easily pronounceable, nalmefene, naloxegol, and methyl naltrexone, etc., which is used subcutaneously, not orally. They are the ones that actually give great benefit from constipation in these patients. Now, this is patients which have a CBD obstruction or SO dysfunction. They come to us either with biliary dilatation or biliary and pancreatic ductal dilatation. These pictures are being kind courtesy of Shams Sharma from Jaipur, who shared it with me, and they have presented this data showing this in patients who use opium. In fact, there are more sort of normal or natural opium users rather than opioids, and see how you can be breaking ahead, trying to look for a lower end obstruction, doing an MRI, doing EUS and so on. But I think a good history would have helped us in making a diagnosis. One of our patients, of course, had a 14 mm duct and landed up with a sphincterotomy and stenting. So when you have an SO dysfunction, again, you need to look at opioid use. The third patient was a 45-year-old male with chronic pancreatitis on analgesics for a few weeks. He came with pain and weight loss, and he had poor intake, vomiting, and distension. And again, this is part of an opiate-related problem, which we call a narcotic bowel syndrome. We do know that the pain pathway goes from the receptors, ascends upwards through the spinal cord and reaches the brain. And the opioids act at that level by giving us analgesia. We also have a descending pathway, which is an inhibitory pathway, which again cuts down the pain. So, but what happens when we have chronic use of opioids? It actually leads to a paradoxical state called hyperalgesia, which is referred to as a narcotic bowel syndrome, or of course, it can also cause opioid-induced constipation by more resorption of fluid as well as slowing down the motility. Why does this occur? And funnily enough, as you increase the dosage, the patient demands more and more dose of these opioids to get relief. What is the reason for this paradox? The reason is that the opiate receptors have a bimodal kind of behavior. It has an inhibitory kind of receptor, and the sensitized glial cells have an excitatory pathway as well. So when you use low-dose opioids, you can just get hyperalgesia. But once you give an appropriate dose of opioid, initially it sort of targets the inhibitory pathway and gives us analgesia. But once it goes to, because it inhibits the excitatory effect, but after some time, there's a tolerance to this inhibitory receptor. And that leads to sensitization of the excitatory receptor, causing hyperalgesia. So this patient takes opioids, he feels better. After some time, his pain recurs. And we interpret it as, oh, this problem has got worse. We give him more opioids. And this leads to more opioids. So gradually, the opioid usage increases. And of course, he's also hooked onto opioid by this time. So this is referred to as narcotic bowel syndrome. And this is, as a definition, I think the Rome 4 has, I think, got it within their list now. It is basically chronic or frequently recurring abdominal pain that is treated with acute high dose of chronic narcotics and may have at least two of the following. That is, pain worsens or doesn't respond with continued or escalating dosages, or the worsening of pain when the narcotic dose wanes and improves when narcotics are reinstituted, and there's a progression of the pain episodes. And you don't obviously do not have an explanation for the pain based on whatever is happening in the body. So this is something that I think all of us should learn to recognize. And once we recognize them, we must learn how to treat it. And how do you treat it? Simple rules are: you reduce the dose of the narcotic by 10 to 30% daily, use longer acting narcotics rather than short acting ones, treat the associated anxiety using benzodiazepines, treat the depression with nortriptyline or duloxetine, which gives us pain relief. And of course, the restlessness can be treated with clonidine. And of course, no doubt about it, that we need to treat the constipation and vomiting. And this is what we did in our patient, that we recognized it, treated his constipation, vomiting, started gradually bringing on the narcotics. And it took us about 6 to 8 weeks for us to get him out of this finally. Why did all this start? If you look at the WHO pain ladder, which came out in 1986, they spoke of the first step being the simple analgesics, paracetamol, aspirin, NSAIDs. Then they said, go up to tramadol, codeine, dihydrocodeine, and finally the strong opioids. But remember that this was postulated primarily and actually mainly for cancer. And unfortunately, clinicians making use of the situation around, they kind of extrapolated it, and we as gastroenterologists started using it for patients with pancreatitis. Surgeons started using it for postoperative pain. Orthopedicians use it for all their chronic back pains, and so did the neurosurgeons. But remember that this approach is essentially flawed, because it's all right in cancer where the life expectancy in terminal cases is small, and so one can use this to give them pain relief. With the end result that for several decades, and perhaps even now, as gastroenterologists, we think that chronic pancreatitis, you have to go through all this, and if it does not really respond to strong opioids, then you consider surgery. I think this obviously is a flawed argument, and we need to treat the patient on his individual merit rather than climb all the steps and then say we can't offer you much, because then once you've reached that stage, the surgeon also is not able to help the patient reduce his pain. The second thing that happened was this big opioid epidemic, which sort of mainly seen in North America, in the US and Canada, to a certain extent in Europe. But if you see that flat curve at the bottom is that of Japan. So the more advanced countries where they had more lax laws on prescription of these drugs, there was almost an abuse by physicians, sort of writing these prescriptions for every single indication. But fortunately, we in India, we have been a lot more sensible, and we don't see this kind of epidemic as yet. For those of you who are Netflix savvy, there's actually a small series called Painkiller, which talks about the opioid epidemic on so-called drug called OxyContin, which is actually a true story, partly fictionalized, but it's very interesting if you read it and see how OxyContin got pushed by the pharmaceutical industry, the representatives, and how doctors became suckers for this. And ultimately, they had millions of patients on these opioids. And it's estimated that about 150 to 200 people die of this every day in the United States. What happens in India? In India, we find that opioids is not so uncommon. But it is not the opioids that are prescribed by doctors, fortunately. It's more of the heroin or patients who abuse whatever drugs that are being prescribed to them and then manage to surreptitiously get it from the chemists and they abuse it. So that's a big kind of reason why we have opioid problems in India. And the prevalence is actually 3 times the global average. And heroin has become very popular and has increased 5-fold in the last 15 to 16 years. And this is official data from the government of India, from one of the centers in the units in All India Institute. So if you see which parts of the country, you can see, fortunately, you're blessed. In Tamil Nadu, it's perhaps one of the least in the country, but it's mainly your neighbors that are catching up, Andhra, Telangana, then the other states in the north, Punjab, Haryana, Himachal, and of course the eastern states, Manipur and Nagaland, they have a very, very high prevalence of 7 to 10% of opioid consumption, largely heroin. So what do we do? As doctors, we need to do good. We also have to ensure that we do no harm. We need to have or respect the patient's autonomy, involving in decision taking, and of course, do justice to his symptoms. So these are the ethical considerations when we prescribe opioids, and therefore, one has to sort of put everything together before deciding that someone goes on to opioids, and we need to educate them about the problems thereof. How do we avoid or minimize use of opioids? Is use paracetamol on short-term NSAIDs in mild to moderate pain. For long-term pain, consider tricyclic agents, antidepressants if sleep is disturbed, or consider duloxetine if the sleep is normal. Duloxetine is an excellent drug for pain relief, or even as an add-on. Gabapentin, we all know, is a great option for neuropathic pain. And of course, close monitoring of opioid prescriptions is done even in the US, but yet they have a lot of opioid abuse. And of course, we need to restrict it. And I'm sure most of our hospitals, the use is pretty restricted. So if you look at the present ladder, this is now a change that has come after that 1986. Now, step 1 is the same. Step 2 says, don't just use opioids, use combination. You can add on an NSAID or some kind of adjuvant therapy, like one of the tricyclic antidepressants or drugs like duloxetine. With step 3, you can go up again further on that and also consider percutaneous techniques for pain relief. So we have many more options, and the importance of high-dose opioids or strong opioids has been brought down. So coming back, our patient who had this burning right side upper abdominal pain and had an ERCP, we actually took a history again, and we found that he had a classical history of diabetic truncal neuropathy. For those of you who are not familiar with this, this is a fairly common entity that we see in diabetics, where they have a kind of a radicular kind of discomfort, pain, burning sensation, or hyperesthesia, which you can just test clinically and find that they're hypo or hyperesthesia, some kind of dysfunction you'll find. And he was not diagnosed and went on to take a lot of tramadol. And then finally he got hooked and he was taking 3 tablets per day. and this is what he landed up with. So we managed him again as the protocol that we have outlined earlier. Summarize opiate-induced GI problems, myriad presentations. The key is awareness, and getting the history, of course, is paramount. And every single history, perhaps in today's world, you need to, just like you take a history of exposure, you take a history of previous surgeries. I think a good thing to do is ask them upfront whether they use opiates, and management can be challenging, especially of opiate-induced constipation. Thank you, and thank you for this opportunity for being here.
Nareshji, that was a phenomenal delivery of an unvisited area. So usually neglected area. So, it was a wonderful delivery as usual. So I'm not surprised because lovely delivery. So on opioids. So I was unfortunately muted, so I couldn't unmute myself. So Pirama helped to get me unmuted. So I have only one question for you on what is the role of naloxone? Now it's available in India also in the ampule form. So in opioid toxicity, would you use naloxone? If so, what are the indications?
No, see, it's because it is injectable. So we use it in more acute settings rather than chronic things. So because it's injectable, I think the need is for drugs like naltrexone and things like that, which are oral. I think that's where we need. Naloxone will be restricted for those in acute situations. Suppose someone has got a lot of ileus and a lot of things like that where you need to quickly get him out. Maybe you could try that.
I think Dr. Basamani has put up a message in the chat box, very poignant reminder of an important clinical problem, as always excellently delivered by Naresh. So congrats once again. I have I just wanted to add on a few things. Like heroin has been there forever in Tamil Nadu also. So, in fact...
I thought there are more heroines than heroin.
Both. In, if you go to Chennai, in Nungambakam High Road, I don't know whether Professor KRP knows, there is a parlor where you can take a heroin, smoke. So it is officially allowed there in that parlor. So at the first floor, I know that a lot of youngsters go there to take a, smoke. And, heroin was there even when I was an undergraduate student in Coimbatore. And even though it's easily available, I think a lot of police cops also help in the sale of heroin. So let it be unofficial, this comment of mine. But whatever it is, we need to understand it's there everywhere. So Tamil Nadu is truly not yellow. So it is probably underreported. I want Professor KRP's opinion also.
Prasad, I'm not aware about this heroin parlors in Chennai. Maybe I should take the sort of address and other things probably.
You should ask our youngsters and Pirama can, fortify the concept.
Those are usually snorted. You snort it or you fix, right? That's what you take it. I think what you're talking of, maybe those shish or something that they have to...
Like a hookah type smoke.
Yeah.
So is there incidence of small bowel strictures, sir, with opioid?
Yeah, in fact, I wanted to put some pictures. In fact, Rakesh Kochar was kind enough to send me some. I saw those pictures, but somehow I am not fully convinced that it is all thing is mentioned. And but I see, how do you prove it? Just because, see, in Punjab and in those areas, there's so much of opium use. To attribute every unknown stricture as opium related would be a little, to my mind, sort of unscientific. That's why I kept those slides out. I know it's mentioned, but I kept those slides out because I'm not convinced myself.
In Bangalore,
there are some publications.
Correct. Dr. Shamsundar Sharma was trained there in Vellore, and Rakesh Kochar, Ajit Sood, they've all got some cases of these because they have a very high prevalence of opium use there.
Nareshi, in Bangalore city, how often do you pick up these cases of opioid toxicity? Because
we do. Just like we're picking up a lot of lead, it's ultimately how comfortable you are with the diagnosis. Once you get comfortable, you ask a question, you pick them up, you treat. It becomes second nature, you know.
Is
It's
it
only the
more
initial
in,
part.
more in youngsters in Bangalore?
No, it's not youngsters. See, those youngsters, they consume small amounts. And those are the aggressive drug addicts. In India, those are the, they don't even reach us. They are sitting in, HIV centers and things like that, rather than coming to us. Ours are more, the pharmacological drugs that are being abused. That is a group we are seeing. We are not seeing too much of heroin and things. It's there, but not to the extent that we are seeing a lot. And even if they are, they perhaps see some other center because that's where they go with abscesses and sexually transmitted diseases and so on.
Dr. Arun Selvan has pointed out in the chat box that tapentadol is used as an addictive in youngsters in Coimbatore, and Madhura has said that they powder it and inject it intravenous. In fact, there was a death in one of the college hostels, so I'm sure LVK would know that. So incident which happened next to his college. So so this was well known, and I was just wondering for acute pancreatitis and pain and chronic pancreatitis pain. So we in the past few months, we've been using this transversus abdominis plain block, TAP block, where we give bupivacaine with dexamethasone. Immediate pain relief is there, which lasts for at least 72 to 96 hours. So you can avoid all these opioid analgesics. Patients rolling with pain also, instantaneous relief has been demonstrated so beautifully by our intensivists.
Very interesting.
There's a comment from Preeti. There's a comment from Preeti on chat box. It is the usage of opioids rampant in Assam.
Mizoram.
Yes, that's true. That's true.
So
especially Nagaland and Manipur, as I said, it's 7 to 10%. 7 to 10% of the population. I mean, it's huge.
Right. The other history that we sometimes do get is people misuse cough syrups. Quite often they are just hooked on to cough syrups for long, and they end up with this kind of opioid dysfunctions, dilated CVD, abnormal LFTs, particularly cholestatic pattern. I think in those cases, unexplained, probably it's good to go back and ask them about.
If you notice that picture I told you of Indian data, is the second after cannabis, the opiates, cannabis, third was these other ones which contains, these antitussives, the stiff, that glue, those kind of stuff. All those addictions come in there.
I think probably we should, history taking, probably should include this history of taking this opioid as compulsory. I think probably we ignore it. We don't ask the patients. Probably we should forget to ask for the history. That's what I feel.
Absolutely well taken points from Professor KRP. I think for all postgraduates who have logged in, please remember any unexplainable problem like what Naresh showed all the 3 cases. You should always think of opioids, and a history taking is of paramount importance.
So I think once again, thanks Dr. Naresh Bhatt for the excellent lecture and information, and over to Dr. Parama and Dr. LVK.
Dr. LVK, sir, for the vote of thanks.
Thanks to Dr. LVK and Parama for inviting me. Thank you.
So it's my privilege to propose the vote of thanks. And first, I'd like to thank Epen and Parama for giving us this opportunity to present this from Coimbatore this time. And my sincere thanks to Dr. Naresh Bhatt, who readily agreed to participate in this and gave a very eloquent lecture. All my thanks to all the faculty, Dr. KRP, Professor Jayanti ma'am, Rajesh, Sridhar, Mukund, and and Dr. Mohan Prasad sir, and all the speakers who presented very well, and an awesome lecture by Madhura regarding Coimbatore. If we want to talk about Coimbatore, we can still talk a long thing. And so I want to thank all of them. And it's very heartening to see that about 65 people logged in for this session. Thank you so much. And thank you, Brahma and Epan, for giving me this opportunity.
Thank you, sir. Professor Epan, any words?
Deepan?
Well done. Very nice. Very enjoyable. Thank you.
Thank you so much, sir.
Thank you.
Good night to all. Good night to all. Thank you,
sir.
Right.
Thank you, Naresh, sir. Thank you so much.
Thank you so much.
Bye-bye.
Thanks, Deepan. Thanks, Pramod.
Arati, hi.
Thank you.
See you all in Bangalore in December.
Yes.
Yeah, sure.
Look forward to that.
December.
We're all awaiting your great hospitality.
Absolutely welcome. Please come.
Thank you.
Hi, Basu.
Bye.
Okay,
PK, how are you?